today we'll be discussing third question, that is name various causes of diffuse hyperostosis of skull. For this they gave 2 marks. Enumerate radiological findings of 2 of them. For each they gave 4 marks each. Total 10 marks. Coming into discussion. Name various causes of diffuse hyperostosis of skull. So hyperostosis of skull can be diffuse or focal. What are the causes of diffuse? We have Paget's disease, metastatic diseases such as prostatic carcinoma, chronic severe anemia, hyperparathyroidism, acromegaly, osteopetrosis, hyperostosis frontalis interna, long-term phenytoin use, genetic diseases like craniodiaphyseal dysplasia, frontometaphyseal dysplasia, Camaruti-Engelmann disease. These are all the differential diagnoses for diffuse hyperostosis of skull. Now, what are the differential diagnoses for focal hyperostosis of skull? We have meningioma, fibrous dysplasia, Paget's disease of bone, metastatic disease, especially prostatic carcinoma, enthesiosneuroblastoma, only rarely demonstrate hyperostosis. So, for this, we have got 2 marks. And now we'll be discussing about radiological findings of hyperostosis of skull in each disease. They asked for 2. Each one carries 4 points. So first we'll go into Paget's disease. Here the radiological findings present within the skull are only discussed. First finding is osteoporosis circumscripta. This is a large, well-defined lytic lesion. It involves both inner and outer table commonly, but inner aspect of the outer table of the skull is most commonly involved. So it appears in the lytic and active phase of the disease. Just coming to it, there are 3 stages of Paget's disease. One is the active lytic stage, there is early destructive stage. Another is the active mixed intermediate stage. Then inactive sclerotic, there is a blastic stage, there is a late stages. There are 3. So osteoporosis circumscripta, it occurs in the lytic active phase. Coming to etiology of Paget's disease, this is a disease of osteoclast. It can be due to viral infection, paramyxovirus, or genetic susceptibility. Its etiology is not entirely known. Coming to X-ray findings, like well-defined areas of radiolucency, they are often large. Frontal bone and occipital bone are most commonly involved. CT, when you see the HU of this radiolucency, they are often those of macroscopic fat, similar to on MR. Coming to MR signal, so normally T1 there will be decreased signal similar to that of muscle, interspersed with foci of normal signal, that is maintained yellow marrow. T2 high signal intensity, heterogeneous pickled appearance will be there due to fibromuscular marrow changes. On contrast also there will be speckled appearance due to increased blood flow on the active sites. This is about osteoporosis circumscripta. The second finding which we see in Paget's disease is cotton wool appearance or something like mixed lytic and sclerotic lesions of the skull. When you see a skull, these are lytic and sclerotic lesions of the skull. So, why this occur? These are due to thick and disorganized trabeculae. Due to thick and disorganized trabeculae, we get mixed lytic and sclerotic lesions of the skull. This thick and disorganized trabeculae leads to areas of sclerosis in a previously loosened area of the bone, typically the skull. These sclerotic patches are poorly defined and fluffy. Cotton wool appearance, there will be lytic areas, sclerotic lesions within the skull. This is one of the findings in Paget's disease in the skull. The third finding is diploic widening. Diploic widening, what is this? This is an expansion of the cancellous bone between the inner and outer tables of the calvaria. This is called diploic widening. Coming to little anatomy, what are these diploic spaces? That medullary cavity of the skull. Location of normal physiologic hematopoiesis in adults. In the so what happens in the setting of chronically increased intramedullary hematopoiesis? They cause expansion. One of the last finding is Tam-O'Shanter sign. Tam-O'Shanter is a hat. So the skull appears like a Tam-O'Shanter hat. Due to platybasia and basilar invagination, the skull appears as if like falling over the facial bones. So in this Tam-O'Shanter sign, there will be widening of the diploic spaces, enlargement of the cranium, and platybasia. The findings in hyperparathyroidism. One of the findings within the skull is salt and pepper sign or pepper pot skull. So salt and pepper sign seen in hyperparathyroidism. Why it occurs? It's due to multiple tiny well-defined lucencies. It occurs because of resorption of trabecular bone in hyperparathyroidism. This leads to loss of definition between the inner and outer tables of the skull and a ground glass appearance, as well as spotty de-ossification. So this is seen in hyperparathyroidism. Then coming to acromegaly. How the skull appears in acromegaly? They have calvarial thickening, particularly of the inner table. They have frontal bousing. They have enlarged paranasal sinuses. This is especially frontal sinus. This is called as pneumosinus dilatans. They have enlarged sella turcica. Prognatism, that is mandible enlarges. So these are the findings in acromegaly. So what will be there? There will be calvarial thickening, particularly of the inner table, frontal bousing, enlarged paranasal sinuses, mainly frontal sinuses, pneumosinus dilatans, enlarged sella turcica, prognatism, that is mandible enlarges. Coming to skull findings in osteopetrosis, it's mainly osteopetrosis. We have autosomal dominant variant and autosomal recessive. Autosomal recessive, it occurs in infants. How the skull appears in them? They'll have the calvaria, there will be diffuse thickening and increased density, which is most commonly involved in the skull base. Calvarial thickening and increased density, mainly the skull base. Due to the involvement of skull base, the foramina present there, there will be foraminal overgrowth, leading to compression of the cranial nerve roots. There will be ocular disturbances, cranial nerves, optic, oculomotor, facial and vestibulocochlear nerves are mainly involved. Overgrowth of the foramen magnum, leading to obstructive hydrocephalus. And in this patient, they'll have high attenuation inner table, broad low attenuation diploic spaces, and a less high attenuation outer table of the calvaria. So other findings within osteopetrosis are they have defective dentition with incomplete enamel formation or caries. Poorly pneumatized paranasal sinuses. Ithmoid sinuses are least severely affected. They will have hypertelorism. They will have areas of increased hematopoietic activity, giving a hair on an appearance. The mandible, they have characteristic triangular opacity representing calcification within the secondary condylar cartilage ossification center. These are the findings in osteopetrosis. Coming to hyperostosis frontalis interna. It's a benign overgrowth of inner table of the frontal bone. Benign bilateral symmetrical may extend to involve the parietal bones. The skull thickening will be present, which is sessile or nodular, and may affect the bone in a focal or diffuse manner. So these are some of the causes of hyperostosis of the skull and their findings. Thank you. If you like my content, just like and subscribe.